Greetings, everybody. How you doing, y'all? This is Joe Driscoll back again with the Salt City Grind. I'm very excited about this episode. There was a lot of response online, a lot of people eager to hear some more about this conversation. My guest today is a mental health professional, but also a dear friend that I've known for a long time, Mr. Sunny Aslam. How you doing today, Sunny?
Glad to be here. Thanks for having me, Joe.
Yeah. So Sunny is actually up in Maine right now. So I thank you for taking the time and making the extra effort to talk with me, even though you had some challenges.
Absolutely.
So, the reason I wanted to have this conversation right now, I would have it any day of the week because there's so much good stuff that you've done and so many interesting conversations we've had. And mostly this podcast and this Facebook stream are mostly just trying to have interesting conversations that I've had with interesting characters in Syracuse, but in a more public format, so more people can engage in the topics and engage in the conversation. But particularly as we've had these conversations in the last few weeks about policing and reimagining policing and trying to change some of the dynamics, I also did a podcast interview with Chief Buckner. And he said multiple times that, he felt that it wasn't something the police were adamant about if someone was having a mental health episode, that they don't feel they should be the first person on the scene. And it brought me back to the conversations you and I had and the meeting we had with Assemblywoman Hunter. So for the people that are watching that aren't familiar with you, maybe you could talk a little bit about your efforts to advocate and expand mental health services in Central New York, and tell us about your effort and how it went and what your goals were and how that all rolled out.
Yeah, thanks. So there have been a number of things I've tried to do over the years, and of course these are big efforts. They really don't have much to do with me other than I just end up getting involved. But we've tried to. I've worked in the public sector. I've worked at Upstate. And tried to expand services for folks who not only who are homeless or who spend a lot of time on the streets or at local shelters, panhandling, people who come to clinics, people who live in poverty, people with serious mental health issues like schizophrenia and also addiction too. We've tried a number of things at Upstate, and when I worked for the Office of Mental Health, which is a New York State-run mental health agency locally at Hutchings Psychiatric Center. I was an outpatient psychiatrist for 7.5 years. So we tried to expand services, and the bottom line is the bottom line. There's only limited funding to provide services, and you always want more because the need is so great, and you see waiting lists and wait times for people to get treatment. So we tried to set up some clinics at the shelters, for example. Other efforts to have walk-in hours for people to be able to see prescribers directly, to be able to be screened to walk in off the streets by counselors. And some have been successful and some haven't. We've tried a number of things.
What have been some of the more successful and what are the ones that weren't successful? And what did you feel the differences were? What led to success and what were the challenges?
Yeah. So a few of the things that were successful were we were able to start a clinic, or we actually changed our service at a clinic to be able to have walk-in triage, so screening, so people could just walk in off the street and be screened by one of our social workers or nurses. And it was fun because we actually had some trainees who wanted to help out too. So people who were learning were getting the chance to help us out with under supervision, of course, but we're able to get a chance to help us expand services. We had walk-in prescriber hours as well. We moved to open access scheduling to be able to accommodate people who had more acute needs. So that was one of our successes. It was fun. It was cool, but it does put stress on the staff, for example. So one of the things is at times, staff are saying, look, we're changing the whole way we do business here, and this is overwhelming for us. So you not only need to to have the funding for positions to actually staff these initiatives, but we needed to keep in mind that staff who had done things a certain way, some of them for 1, 2, 5, 10 or more years, were suddenly being asked to just open the doors and see people walk in off the streets, which is a great service for the public, but overwhelming for staff. So they needed a lot of support as well. Some of our failures, I would say, I set up training clinics at 3 local shelters, and we tried to set it up in a private practice model because we didn't have any funding. There was no funding to actually do it. So it was just go in there and try to bill Medicaid basically, or whatever insurance people have, and then see if we can break even. And we couldn't even come close. And so after a few months, unfortunately, we had to look elsewhere for contracts, or to do this differently. And the contracts didn't come through. So we ended up moving in a different direction. So that was pretty upsetting for me, but
yeah. So the biggest obstacle you faced in trying to expand these kinds of services with mental health was, as usually is the problem, was the financial aspect. Yeah. So you guys just weren't able to make things break even with the expansion.
Right. So that was the primary issue. There also is, of course, when you have different agencies involved, people don't always get along and trust each other. And so we spent a lot of time over the years trying to build trust as well between competing agencies, because everybody's competing over the smaller and smaller pot of gold to help very ill and very desperate people. Their staffs are overwhelmed, their staffs are overstretched, and this group gets this money and that one gets this money from the city, from the county. And people get upset. Unfortunately, there's the scarcity mentality, because there's only, the sense is there's only limited amounts of money over there, and it's a zero-sum game. So we all have to fight over what's out there to help who we think needs it the most.
Right. So when you guys were trying to expand these, so the effort you guys did was kind of like a walk-in type situation. Is that correct? Or you guys went out on the street and dealt with folks?
So we've done both of those. It just depends on which specific effort you want to talk about. We've done it in the clinics, we've done it on the streets, we've done it in the shelters. Some were successful, some weren't. So right now the shelter programs are just when we can do it, just when there's time or when there's a need. One contract came through, for example, but others didn't. So we do what we can. So it's a mixed bag right now as far as what's really available. For example, at maybe the shelters or on the streets, right. It's the services are pretty limited.
So if we were to do something, so first of all, I guess framing this in this conversation, as you and I spoke about initially. Some cities have developed these more extensive mental health services, right? Like they're in place of, so say we have, for example, we have, in my district, there's a few areas where there's our homeless community that have addiction problems, mental health problems, and to continually call the police into that situation seems like we're using the wrong medicine for the problem. And I think police feel that way, and I'd assume a lot of mental health professionals feel that way. Maybe talk to us about, are you aware of some cities that have come closer to getting this right, that have this kind of thing, that when we do see a person having mental health problems, a homeless person that's having mental health problems, cities that have developed a response that meets mental health problems with mental health professionals?
Yeah, absolutely. So one of the more hopeful things that's happening now is that our federally qualified health center, Syracuse Community Health Center, has potential funding available to it that other agencies locally don't. And so, we're always talking and working with them to, in hopes that they will tap into that. It's complicated as federal money is, of course.
Right.
There are a lot of requirements, benchmarks, et cetera. So it's not like you just sign up for it and the pot of gold appears. It doesn't work that way. They need to make sure it's a sustainable program for them. But that is what runs a lot of homeless care in many cities. So Rochester, Buffalo, North Country, downstate, they have access through the federally qualified health centers for healthcare for the homeless is the name of the program. And we're hopeful. And Mark Hall, who's the wonderful CEO at Syracuse Community Health Center, has expressed interest in tapping into that funding, which again, none of us have any access to that, but he does. And so hopefully Syracuse will we'll take advantage of that money soon, and we'll have those services available to us.
So when you say that the federal money, do they is the issue now that they have the ability to tap into these kind of grants, or that they already have the funding there? It's just a matter of deciding how they're going to utilize it and how they're going to, to which programs this kind of federal money is going to go to. Is that the conversation, or is it that they have the ability to tap into these grants and they haven't received them yet?
So it's an application process. You don't just sign up. It's complicated, but I can't imagine they would be turned down for it, because we're the 9th poorest city in the country, #1 by ethnic poverty. Yeah. But they just have to apply for it when they feel the time is right. And, certainly a number of us have encouraged them, and they seem interested. So I think it's just a matter of time. Maybe the next time the money, there probably are different deadlines or openings for applications, and hopefully they'll do it. In the meantime, I've applied for some grant funding from private agencies, and I'm hopeful. I've been told that they loved our application, but it was a money issue. There was a $9 million grant, and $4 million was funded of it, so we need to make up $5 million. I don't know where to get that, but the foundation said they do. So my hope is some of that money will come through as well.
So your grant for $9 million, what would that look like if you got this? If you got this $9 million, what would be the type of programming you would roll out, and what would be your aspirations?
Yeah, so it's called critical time intervention, and a philanthropist group is really wanting to. There have been some studies done showing that the money that's put into this, it's like a case management, an intensive graded case management program that it's over typically 9 months for people with schizophrenia who are either homeless or at risk for homelessness, and it's to help transition them into the community so they're not in, living in institutions, jails, homeless shelters, that kind of thing. So that money would then, there are 3 sites. It's for a study, actually. It's a research grant. And so there would be 3 sites for the study, and we would be one of those where we would get a number of resources to have these case managers go out into the community, to the shelters, be it the upstate emergency department, maybe local psychiatric hospitals, and help people transition out of homelessness or being at risk of homelessness, and to be able to live stably in the community and to have affordable, safe housing.
Do you know off the top of your head, and again, this is, if you don't have it, don't feel bad, but I'm just curious, off the top of your head, do you know kind of, I guess they would say, like, recidivism rates for for people that are, when people are in jail or whatever, but do we have any data about how many people that are, have problems with schizophrenia, end up homeless? How many of them are able to transition back into being, medicated, independent on their own? Is it something that we have a good rate if enough resources are there? Or do we have any data about how big of a lift is this to get our schizophrenic, mentally ill people back into functioning members of society? What are the chances and the odds?
Yeah, so it's a great question, and of course the answer is really complicated, but let me try to break it down the best way I can. So the 2 things that come to mind are, that's why this foundation wants to do this, to give the money to this work, is because they recognize there were 2 large studies done that showed that a small but significant investment per person really helped people stay out of jail, hospitals, and homelessness. And of course, if you can keep people out of institutions like that, you actually save a lot of money. So
right.
Our tax spending will go way down if we keep people out of psychiatric hospital, where it's $500 to $1,000 per night. We could put people up at the Sheridan in town for half the cost, or less than half the cost, of what it costs for people to be at Upstate overnight or Hutchings Psychiatric Center. And so these are not small numbers, but it's very hard to convince people, funding agencies to put the money up front, because everybody wants money up front, but it's
right.
It's very complicated. So that's I guess the first thing that comes to mind about the other part of the answer is really complicated. There are studies, long-term studies, that show that we used to believe, and we're taught in medical school, that people with schizophrenia don't ever recover, they don't ever work, they just need to be taken care of by people, doctors, or live in group homes. It's not true. Actually, there's one study published in way back in 1987 that showed that 1/2 to 2/3 of people with schizophrenia have significant recovery, which means they go to work, they have families, many of them even get off medications, but it takes a long time. The study was a 34-year study, so it took years and years of what we call psychosocial rehabilitation, giving people family support, outpatient treatment, giving them job skills and job training. The goal is for most people is to work and to love, and so to help people, to give them the skills to do both for some people is it takes time, and it takes money too, but it is something that can be achieved, and we see that people do recover. Same thing with addiction. Addictions kill people. The opioid crisis and tobacco are killers, alcohol. But people, when they do get into treatment, many of them are able to get well. And then they go back to work and have families. But these are illnesses that are, they're not for the faint of heart. Homelessness and addiction are really disorders about treating trauma. So people have been abused, neglected, physically, emotionally, sexually, and it takes a significant investment in treatment and financially to help people get their lives turned around.
But the belief there is that this would actually be incredibly cost effective if you invested up front, rather than in the same way that Medicare for All would reduce the spending on emergency room visits and the bureaucracy of stuff. In the same way, if you put this investment up front to deal with the schizophrenia and the addiction issues, you wouldn't be seeing the higher costs on the other side, right?
Correct. Yeah. I mean, I know you lived in Europe for years. You go to Norway, you see a 4% poverty rate. We have 17% in the US. So you just see we have such a fragmented healthcare system, so people can't consistently access not only medications, but the treatment, the therapy, the addiction treatment that they need to help them stay sober, or to get the job skills, to get their symptoms under control so they can go back to school. Many of them want to go to school and go to work. But unfortunately, we just haven't made that commitment in this country yet, in all 50 states to it. But my hope is, with things like Medicare for All, the county expenses would probably go way down instead of people going to the emergency room, or going to jail. The Chief Buckner's folks are going to be called to deal with people who are, drunk, high, disruptive, because they, have lost their insurance. They didn't recertify their Medicaid. The county is going to pay for Medicaid costs. So yes, the general idea is let's provide the treatment up front, the funding up front. And it's nice that we have a chance to get a grant from a private agency. I'm 99% sure it's going to come through, but there's always a chance they decide to go somewhere else, and I certainly hope that doesn't happen, because we desperately and urgently need the money in Syracuse to help those who live in severe poverty here. So
I couldn't agree more. So I know I'm asking you kind of tough questions here, that data that's hard to acquire, but I guess that's why I'm asking a lot of them. Do we have any estimates? For example, in my district and in downtown, we see a lot of the same characters. It seems like we see the same, 7 or 8 characters again and again. Oh, there's so-and-so, there's so-and-so. And we know these homeless characters that have mental health problems that we've interacted with a number of times, and kind of repeating characters. Do we have any estimates number-wise of how many individuals are like this in the city of Syracuse or in Onondaga County? How many homeless people battling with addiction and mental health, that this crossover area that would be your target population that you'd be trying to deal with? How big is the scale of the problem? Do we have any idea of numbers and how much lifting it's going to take to start addressing this and make an impact?
Great question. So I don't have the exact figures in front of me right now. I know that I was unpleasantly surprised that our estimates from our statistics folks were much higher than I even thought. So we wanted to, in the study, we wanted to look at working with about 300 to 400 people. And It looked like that was not even going to cover the people who are in the most severe circumstances. So that was upsetting to see that. But
Do
yeah,
you
so
know?
then,
Do you know how much? I mean, so 300 to 400. Do we know if that's like half, or is it to a scale of 1/10, or do we know? Or I know it's got to be. Obviously, there's a lot of gray areas in here about people who are housing insecure versus homeless, people who have, you know, recreational addictions as opposed to hardcore, drug addiction. I'm sure there's a lot of gray scale in there, but as far as this crossover, this 300 and 400, does it feel like you guys would be, if you could say the program is really successful and you were able to rehabilitate these 300 to 400 people, would you be solving? Would you get to 10% of resolving, the health of the area, or would you be halfway there? Something like that.
so one of the good parts and one of the bad parts of the study is that you have to have a comparison group. So half of those people would get treatment as usual, which is okay and not awful in our area, but it is just that. It's the usual treatment, and then the other half of the group would get the extra case management services that the grant is looking to study. So really, we're only treating half of those with the intensive model, and the idea is to show the difference, show that, hey, that group did great, so that we can get, it's to encourage federal funders and state funders to put more money into these types of programs. So, but to answer your question more directly, I don't know, but my sense is that we were looking at, maybe it was going to be about 2/3 of the group that were actually going to be in the study. That's a guess, though. I don't remember exactly.
Okay.
Yeah.
But I mean, outside of that group of 300 or 400, I mean, just to say, like, are you guys, is this group of 400 that you're looking at, or 300 to 400 that you're identifying, does that seem like, are they 300 to 400 out of 4,000 in Syracuse, or are they 300 to 400 out of 800 in Syracuse? Do you know what I mean? Like,
Yeah.
I mean, obviously you don't know exactly, but do you have any estimates or guesses?
So we did, and that's what the figures I don't have in front of me exactly. I can give you some numbers like what I think.
Yeah, just ballpark. I'm just curious if it's like half or a tenth, like something to that scale. Like, are we looking out of like the 140,000 in Syracuse and the 400,000 in Onondaga County, whatever? Are we looking at, tens of thousands or thousands? I just have no idea of the size of the problem.
Yeah, so the study was specifically for people with schizophrenia. So that's 1% of the population at baseline. So these folks, and it was based on data that came through the upstate emergency department, where they saw a ton of people. And so my best recollection was it was something that was like 400 or 600 per year. And then we were going to be able to maybe do 300 or 400 with only half of them receiving the treatment. So we're really touching a small group. And the other piece that we haven't even talked about today is, in mental health and addiction treatment, people have to want treatment. And,
Yes.
and many of them are not well. They're not well. I have addiction in my own family. I have serious mental illness in my own family. And some people don't want treatment, and we can't force treatment on people. So we can offer them these options, but many of them are not even well enough to be able to say yes or no. They're paranoid of you, or they're frightened, or they're just not in the mental space to be able to say no. And we can't provide treatment or do research on people who won't give us permission. We have to, respect their constitutional rights just like anybody else. So you can see this gets complicated very, very quickly. But many people will take it, and many people will benefit from these types of treatment to help them get housed, to get to treatment, to get sober, if they want it. But that's the other piece, is we can go see the folks in the community you're talking about every day until our faces are blue. And sometimes it takes days, weeks, months, or years before someone will even say, they see the doctor come and they say, "You're just a pill pusher. I don't even want to talk to you."
Right.
So we don't even go in talking to people in the beginning about taking medications, or we may bring them some socks and a sandwich. It's all about engagement, because we have to build a relationship, or they're never going to trust us. Many of them are already just so paranoid or psychotic or high or drunk that they don't, if you're not offering them something that's going to help them get through today, they swear at you and tell you to get away from them.
Yeah. And that is, I'll go to some of the questions we got from online, and I see there's a lot of comments coming in as we meet. These are some of the comments we got from Facebook. So more to the, I was kind of framing this in the context of, as I said, as I promoted the episode and as I spoke to you, I feel like, we're using a hammer when we need a screwdriver when it comes to mental health response, right? Like we send police in, typically ends into the, prison system or the legal system. And a lot of times what we need to do is get them into the health system. So it's kind of like we're using, but one person said, I'm not sure about this. Showing up to deal with a mentally ill person alone, is that a good idea? Police should be there on standby. What if the situation turns bad quickly? And so the person was asking about, if you respond as a mental health professional, what do you do in those situations? One, how often is it that people do turn violent, or people, are in the midst of something, and then all of a sudden you realize, we actually did need a hammer or whatever, in that analogy, that we actually have picked the wrong tool, that if you send out a mental health professional, perhaps at times people are violent or wanting to be violent. How often do you guys encounter that in your experience? And how, if something like this was to be launched where we sent in mental health professionals instead of police, how do we address that concern that we're sending mental health professionals into a situation that could be potentially violent?
Yeah, it's an absolutely fair group of questions, and so it all depends on context and experience. And so I've been doing this for a long time. I'm a man. I'm 6'1", 180. I've never been threatened or harmed by any of these folks. But I will say, my ex-wife was assaulted. So these things do happen. Thankfully, they're very rare, but they do happen. And so we have protocols set up that if the person has a history of violence, they haven't been doing well lately, we might do a 2-person visit. So we do have things, processes in place to make sure safety comes first for everybody. Is it a woman going alone to a visit? What part of town are they going to? What time of day? So we use a lot of data to understand and make sure there's safety. If you do look at the statistics, and so science is important here, we do look at the statistics. The group of folks we work with, particularly people with schizophrenia, are much more likely to be victims of violence than they are to perpetrate it. Now, addiction can be a little different. So with addiction, drugs and alcohol, being inebriated it's one of the most important risk factors with violence. So, there's no easy way. In fact, you can't predict these things, but we can make educated decisions to make sure everybody's safe. But it's thankfully, usually people with serious mental illness are much more likely to be victims of violence than to perpetrate it.
I believe that's what some people push back on in the comments on that. So here's another question we got. I'd be curious to know what plans there are for people transitioning from short-term emergency mental health care, which in itself absolutely needs expanding, from them getting into long-term treatment. It can be such a long process to access therapy in this area, and the wait time can often be months. That's often too long for people to go through on their own without another emergency situation occurring. So, do you care to comment on that? Any thoughts on, trying to make that transition from short-term to long-term, and the capacity issues with both of those concerns?
Absolutely. So, very fair assessments. I will say I do believe things are changing. So a number of agencies in town now have walk-in services. We have walk-in services at Upstate now, at Upstate Addiction and Pain Medicine. So somebody with a support person can walk in Monday through Friday, 8:30 to 4, and be assessed and see a prescriber at the first visit. In our clinic, you see a prescriber at every visit. Many clinics, it's not to devalue counselors, but you're seeing somebody who can't adjust your medications. And that's often what people urgently want is, I'm horribly depressed and nothing's working. I need my antidepressant or my antipsychotic medication adjusted because I'm hearing voices. And so we have adjusted our services to be able to have that walk-in service available where you see a prescriber. And there's 5 of us who are prescribers that are there, either out in the community or working on site. We have telemedicine available now. So I think, COVID has been terrible, but one thing that has forced us to expand is to be more accessible by telemedicine. So on Tuesdays and Wednesdays, 1.5 days of the week, I'm just doing telemedicine. So people could be able to see me through WebEx or Zoom or FaceTime or whatever secure links we can have to offer telemedicine. But I do believe there has been a significant effort locally to expand access to care, walk-in care, and expand access to prescribers. I do think that we may be the only upstate addiction and pain medicine, the only place where you see a prescriber at every visit, including the initial. And I think that's pretty unique. So people definitely can call our number. If you have any addiction or pain issue, you can call or walk in. It's better if you call, because sometimes you have to sit and wait, and that's not fun. But we really have tried to make efforts to address people's need to see prescribers and get their medication on the first or every visit.
And I'm sorry to keep going back to this one, but if we could just, so you mentioned that that upstate sees between 300 to 600 type of individuals like this a year, right?
That's my best recollection of what the data was when we ran this, and that was a couple of years ago. So I don't know what it is now, but that was.
I'm looking for ballpark. I won't hold you to exact numbers, but how many other touch points are there in Syracuse? So if someone has these types of issues, are there a lot of other agencies where they would be touching, or would upstate be the place? Would you guys see the bulk of the people that are dealing with these types of issues?
I think the other major points are the other emergency rooms, in particularly CPEP, the Comprehensive Psychiatric Emergency Program at St. Joe's. They would see a huge number of folks like this. So I think the upstate emergency department, emergency medicine, and then St. Joe's CPEP would be the two major places, at least as far as hospitals. The outpatient clinics are very busy. There's a number of clinics in town. We're just one of them, but there are a number of clinics in town that do terrific work, that see a lot of people on the outpatient side of things.
So here's another question we got from online. How do mental health professionals respond to individuals that don't want help? I know currently law enforcement has their hands tied in a lot of these situations due to a lack of consent. Repeat homeless, schizophrenic, and issues at local businesses, loitering, then they refuse treatment, and often they're not breaking laws except for maybe trespassing or solicitation, but you still have this issue. So you spoke to that already. We already touched on that briefly, but if there's anything you want to expand to, you mentioned, providing sandwiches or a pair of socks or something to make that intro, but also generally, how do you guys cope with people who just don't want to be helped?
Yeah. So this is difficult because there are people, my mentor had a saying that, psychiatric and addiction help is for people who want it, not people who need it, because in the end, people have the constitutional right to refuse treatment if they don't want it. So there are a lot of wonderful agencies in town, In My Father's Kitchen, John Tomino and others, who go out on the streets and do this engagement work to try to engage folks, because the pressures on those of us who work at clinics is to bill. And we can't bill for patient visits with people who don't want treatment from us. So thankfully, there are folks out there doing engagement work, for the county, for peer groups. There are people out there doing wonderful work, but it's a complicated, very upsetting thing when you see someone very ill, you offer them help and they tell you to get lost. So I think all of us are in it for the long haul. We just try to engage these folks and build that relationship in hopes that one day they, surrender and say, yep, I need help. I need the help, and they will come and get it. And sometimes it's over and over and over again. They come and then they go back to alcohol or back to opioids, or they're in and out of the hospital, in and out of jail, in and out of homelessness. And, that's why we focus so much on taking care of each other in mental health, because it's traumatic for the staff to go through this over and over again, and people die. Patients die. Our folks, they overdose, they kill themselves. It's really harrowing. So the next time you talk to a mental health professional, thank them for the work they do, because we've been lucky the past year or two. The deaths have been down, but a couple of years ago we had a number of people dying from opioid overdoses, and it was very upsetting.
Well, I thank you for your service, and thanks to all your colleagues. I
Thank
appreciate you. You know,
thank you.
so if we were to do some kind of program like this, again, bringing this back to kind of my thesis with um, uh, our discussions around, sending out a mental health professional instead of the police. If we were to do something like that, how many additional mental health professionals do you think we would need to have the capacity to, whenever the situation arises? And again, I know there's a lot of grayscale in there, and there's a lot of nuance to that kind of question, because it's there's obviously a lot of nuance to how extensive the response would be, and how much. But in an ideal world, if you were to get what you think a successful pilot would be to going, how many mental health professionals do you think we could have that would respond to mental health in place of using the justice system to deal with them, have the mental health system deal with them?
That's a tough one. I mean, it'd be nice even just to start with a couple of social workers and a nurse, who would cover the week, in some kind of rotating shifts or with some overlap, to be able to be available to do the engagement work. Maybe in concert with John Tomino and some of the other peer folks from the county. I mean, there are wonderful people already doing the work. I think it's just adding the layer of the, medical care, mental health care, the addiction care. And these are the things I think we're working on. And the community health center, I think, will move more and more towards this. They're already doing a lot of great work. So I think we're getting there. I think, maybe the grant will come through. The private grant, the federal money as well, and maybe we could have just a few folks doing some of this work and take some of the pressure off the police. It'd be a great place to start with just 2 or 3 staff, and then we would look at it, because you always want to look at the data and then see maybe that's too many. I don't think so, but my guess is all said and done, maybe 4 people for the city of Syracuse, and maybe 6 to 8 for the whole county might work. But I'm just making these numbers up. I don't know,
Well,
because we have
at least it's good to have that conversation about what a pilot, what a first step might look like, and that's kind of what I was asking. I think you've answered that effectively, to say 2 to 3 for the city, maybe 6 for the county. I think it's a good place to start. So maybe we could talk a little bit about that. I've had conversations with a lot of different people who work for a lot of different agencies, and I don't want to go into any areas that you don't want to talk about or don't feel comfortable talking about. But you mentioned John Tomino for one, and I believe Liberty Resources commented on the thread saying that they were developing a program similar to this. So maybe talk about some of the different agencies that are working in this field, and what how the different services vary, or is there a lot of overlap in trying to do the same services, or is everybody finding their lane and working together, and how would your grant fit into the ecosystem that's already there, and how would this differentiate from all the other agencies that are out there, and how would you guys work together in trying to develop a cohesive plan for the city and the county?
Sure. So I think it is very difficult. I think we work in a really fragmented healthcare system, and that's evidenced locally. I think there's definitely been a lot of trust that's had to be built between some of our partners locally. I think the encouraging thing that I've seen is that some of the mistrust has been able to be put aside at times. At other times it hasn't, and we've had some major upsetting things that have happened. But my hope is that between what's happened with COVID and what's the ongoing suffering in one of the poorest cities in the country, that just continues. I mean, there are no easy solutions out there. So I'm hopeful that we'll be able to work together more and more. But the realities are, it's difficult. It's difficult, right. And there's a feeling there's only so much money out there. But I will say, a number of agencies locally have stepped up and are doing more to be accessible in a really difficult climate. I mean, running a nonprofit in an extremely in central New York, I don't know how some of these agencies do it. I mean, it's just almost impossible. But there's more trust to be built, and we need more and more leadership in Syracuse to bring everybody together, because it is really difficult at times. And of course, who suffers are the poorest folks at the bottom of the rung. There's often nobody speaking up for them, while the rest of us try to fight over the money and how best to spend it.
Yeah. So if you don't mind, I'll go into I got two people that kind of opened up about personal stories. And so maybe I'll share those two stories with you, and tell me your thoughts on it. Because I'm sure it's something, this is probably a story that's all too common, because, you know, both these people commented on my thread back to back. Would the courts be in any way able to mandate healthcare programs for offenders or prisoners that are returning to the world, focusing on rehabilitation, but especially those with mental health concerns? Mandating meds, I understand, is a rights issue, but I can say firsthand that I wish that there was some way they could. Seeing someone you love struggle for years using drugs to treat themselves, going to jail time and time again, and then never using medication. A friend had it in jail the last time, and when he left jail with no health insurance, no meds again, led him into a horrible manic episode. Within 6 months, he was back on drugs. I know this is a common cycle. How do we begin to try to change this dynamic? And then another woman commented below that saying, I had the exact same thing. It keeps happening to my ex-husband. He desperately needs the meds for his mental illness, gets what he needs in jail, but as soon as he gets out, it's a few months before he starts self-medicating again. He is in prison for 10 years now for robbing a gas station, only getting about $40 for the fix out of it. So sad. He'll miss his kids and their entire childhood, and all he needed was a little help to keep him mentally stable legally. So again, this goes to something we've talked about a few times throughout the episode, and I know it's one of the biggest challenges that you face in your career. Again, people who don't want help or people, but when we get to something where people are a threat to themselves or a threat to society, have there been any new discussions about exploring the legality of you know, trying to, and I think some of this is when people come back and they don't have health insurance as well, right? Like people who aren't able to access their meds and stuff like that. So maybe talk about some of that, about how do we get meds to people, and how do we convince them that, you know, to stay on the right path after they've been there in prison, and how do we make that connection between prison and getting back into society kind of things?
Yeah, it's very difficult. Often people are often discharged from prison with little to no planning, and sometimes even when there is planning in place, the person has no interest or no intention of following up on treatment. You know, that's complicated by exactly what you said. People's health insurance may have lapsed, their benefits may have lapsed, you know, and then they feel alone and abandoned, and often turn to drugs, alcohol, sex, gambling, you know, you name it, whatever compulsive activity can cover up the horrible feelings that they have of abandonment from childhood, whatever it is. And so, you know, there have been efforts, and there are ongoing efforts in Syracuse, including drug court, recovery court. There's something called assisted outpatient treatment. But I will tell you, the data is very mixed on coercive treatment. When people are mandated into treatment, often they become passive aggressive, angry, resentful of the system, and mistrustful of it. And the data shows, you know, for example, for assisted outpatient treatment, the studies are very mixed. Some people seem to benefit from it. Other people, it didn't seem to benefit them at all, and they're more angry and disconnected from their treatment providers. So if someone, for example, is mandated to come see me, how do you think they feel? And how do you think I would feel about trying to build a relationship with someone who hates me because they're there because the judge said, you either go to see Aslam or you're going back to jail? So it makes it very difficult to have a relationship where they trust me enough to talk about, for example, their trauma from childhood. Mom and dad physically and sexually abused me. Are they going to tell that to the person the court's making them go to see? In some cases, they will. In some cases, they will grow in the relationship. In other cases, the amount of resources spent sending the police, the ambulance, whoever to pick them up and make them take their medications or make them go to the hospital, and then the hospital gives them the medication. It's not easy to say, where do you draw the line here? And usually, as you pointed out, it's exactly where you said. When someone is threatening to kill themselves or others, the police have to get involved. We don't. I can't stop someone from hanging themselves somewhere. That's not in my, in my tool set. That's when the authorities get involved. We leave that as the nuclear option because, again, when we call the police, when we send people to the hospital, then we lose our relationship with them too often. They won't speak to us anymore. Yeah. So you can see this gets very, very complicated, but there are efforts to do, like the three examples I gave: drug court, recovery court, and also assisted outpatient treatment. Treatment over objection is another thing where a physician can take somebody to court and force them to take medications. We don't like to do any of this because it really is coercive and it's against people's fundamental constitutional rights. But when they are violent and committing crimes and over again, often physicians are left in positions where we don't have any other choice. We can't, we're obligated to protect the public. The public safety is what has to be protected. So it puts us in a very difficult position. But
well, you really provide some insight there. What you're saying is, there's often when you're on the outside of something, you think, why can't we just make this so? Why can't we just make this happen? But then as you're explaining, it's like, yeah, of course, if you're trying to get someone, the long-term success of so much of this is based on trust and opening up and being willing to trust someone to show them the most vulnerable and painful parts of yourself, which is, something many of us struggle our whole lives to open up and show. So to convince someone to do that mandatory, on command, I can see the futility of that and how more resources may well be wasted in trying to force it rather than trying to be, continuing to offer rather than trying to mandate. So I have just a few more questions here, and then maybe I'll look at the comments we're getting live as we go. I'd like to know Sunny's comments on the state of funding currently, federal, state, county, local, for mental health treatment, especially for the seriously mental ill. It feels like there's been a wholesale transfer of mental health treatment to the prison system, is this person's comment. So care to speak to that at all about where the state of funding and how the prison system factors into funding at this moment?
Sure. I mean, there's a long history there. We don't have the time. I think your listeners don't have the interest, but that's, of course, the funding is woefully inadequate. It doesn't allow us to treat folks in the way we would like to. The private health insurance companies really make it difficult to be able to use the treatments we want because they bury the physicians in paperwork, prior authorizations, denials. The health insurance, when people's health insurance lapses, they can't pay for their medications, so they don't get them. It just becomes very disruptive in our healthcare climate. But yeah, of course, the funding, we choose to spend money on things in this country that just don't make sense to me. It's more of a political discussion. What do you think money should be spent on in our country? Should we get testing for COVID, or should we buy more missiles, bombs, guns? It just doesn't make sense to me, but those are my political beliefs. But what I see on the inside is, just that we struggle to keep talented prescribers who can help treat schizophrenia. And, one of the main modalities we use to treat people with schizophrenia and serious mental illness are antipsychotic medications, and you can't get those unless you have a prescriber. And it's hard to keep prescribers. People want to go. You come out of medical school and residency with a crushing burden, and it's tempting to take a private job somewhere and make a ton of money versus working at Hutchings Psychiatric Center, where I had the time of my life for 7.5 years. It was hard work, but the people are so grateful for having a shrink around for 7.5 years that they could trust and come and see. But it's the funding is very, very difficult because everybody wants to shift the cost somewhere else. Federal government to state, state to county, county to city, et cetera, et cetera. It's what you see all the time, I'm sure, on the council, and it's very, very frustrating.
Yeah. So we've gotten some great comments here. I wasn't. It's often difficult for me to, I like to have these as conversations where we're just honestly bantering back and forth, and I'm asking questions and paying attention to what you're saying. But I love the live comments that we get on the feed. So one comment was from Colleen Gibbons saying that the most recent bail reforms enacted by Cuomo in April, treatment can be a condition of release. Assigned counsel office also has social workers who can help offenders access Medicare. So that's good information. One person here was asking the number of when we talked about the number between 300 and 600 at Upstate. And again, I know those were just ballpark numbers. Is that the number of people or the number of visits? And also, one person could create 10 visits to multiple locations. Is there a sharing of info between all these different services for outpatient?
So these are all great questions. So it was number of people in a year. That was my best recollection of that. It wasn't individual visits because a number of them are the same, same group coming to the emergency department over and over again. The other part of the question was about, Joe, remind me, I'm sorry.
The two part of the question was, is that the number of visits or the number of people when you talk about 300 to 600? And then are you guys all sharing info?
It was people. Those were individual people versus visits, which is important to make the differential because some people come repeatedly. And then as far as sharing information, so that is another area that's difficult. When there is competition between different agencies for funding and for patients, I don't think data is shared as much. I remember when I was at Hutchings, we tried to be pretty open and transparent, and understandably from other places they weren't as willing at times. Like I said, the nonprofit running nonprofits is almost impossible in our climate, and there's a feeling of what I think giving away data is like showing other people your playbook, and it's hard, it's difficult, but I think that's the reality. I'm not ever going to be popular for saying these things out loud, but that's okay. I don't blame, or I'm not angry at anybody about that. They have businesses to run, and they have a lot of people they help. But
it's the nature of the beast.
Yeah, it's the way the system is set up, and it's unfortunate. I think our county has made a number of efforts to try to work together and let's look at the data together. So I think that's very much appreciated by all. But it's a sensitive area,
Yeah. Abraham Massara is on here saying that culturally tailored care is key, and they do good work at the shelter there. Another question from Virginia: when will you know if you got your grant?
I had hoped we were going to hear before now, but then of course the world went upside down a few months ago, and the last I heard was they were still trying to raise that other $4 or $5 million, and I don't know when. I'm used to living in Syracuse, where the idea of raising $4 or $5 million is insane to me. Like, where would you even raise that? But the foundation we work with, that's what they do. So they seem pretty confident. Where I was like, $5 million? You've got to be kidding me! This isn't going to happen. But what they told me was, and this would be unfortunate if it happens, but if we can't raise the 9, if we can raise 5, 6, 7, we would just serve less people, which again would be very unfortunate. But at least it's something. And my stance was, look, this would be bringing, $1 million, $1.5 million, or $2 million to Syracuse for jobs here. This is going to provide jobs for Syracuse. It's going to provide treatment for some of the sickest people, around. So whatever, if it's 1 million, if it's 2, if it's 3, we'll take it. We need the money for jobs. We need the money for treatment. And so I'm hopeful.
And again, this is something, there was a great book. One of my favorite books I read was called Zero, The Value of Nothing. And it was based on the Oscar Wilde quote that nowadays people know the price of everything, but the value of nothing. And much like lead, seeing just the cost of treating people with schizophrenia or mental health or homelessness or addiction, seeing just the cost and saying, oh, look how much we're spending on these people. as you said, there's the jobs that are created directly as well, but also the general health of our environment, of our community, that these people will not be, out there, harming themselves and creating, this dynamic out there. What are the economic ripples of that across that? We have a functioning member of society again, instead of someone who's, out there in distress. That has ripple effects as these people become functioning members of society again. And, as you said, I think that's an important thing. So 2 questions. These questions are great that we're getting in the comments. Do you know how many vets, what percentage veterans make up of the people that you deal with? Is it frequently? And the other 2 questions were, how do we talk about drugs? Does marijuana create issues? Do you frequently see people that have mental health issues connected with marijuana? And how does poverty relate to the creation of breakdowns or snaps? So those are 3 big questions that are great.
Right, we could do an hour on each of them. These are great questions.
Right. I'll have to have you back because these are good questions.
Yeah. So let me just try to be brief. So the veterans, I want to give a shout out to the VA, particularly our local one. I don't see a lot of veterans. I think the VA is not perfect. None of us are. People will tell you terrible experiences they've had with me or our clinic too. But the VA does a really good job, I think. That's my opinion. And the data really backs it up. It's not perfect, but the VA does a great job. I don't see a lot of veterans. Now, so cannabis, so marijuana, many of you know we're vocal, me and some of my partners, about legalizing it. We're addiction psychiatrists, and we believe you have to legalize it, but we don't believe it should be done privately. We believe the government should run it. So all the money from selling drugs to people comes back to the government to pay for the harm it's going to do. We know people are going to use marijuana. They do. It's illegal, right? So let's sell it ourselves safely and then collect the money to give people treatment, because they're going to become addicted, many of them. So that's the cannabis thing. The other part with cannabis is, of course, there's the K2 spice or spike that's out there. That has up to 250 times the potency of THC in a joint, or that you get, from your buddy or whatever. And that makes it hurts people's brains. It's dangerous. It makes them aggressive and violent at times. And so that is extremely popular. And let me tell you, the drug dealers hang out and prey on my patients. They know when they get their checks, they go to the shelters, they hang out outside. One day I was walking into the shelter and somebody tried to sell me some of this stuff. And I said, I'm the addiction psychiatrist. And the guy looked at me and said, I should probably come see you. I'm not kidding. That actually happened.
And was he saying it humorously or in earnest?
No, he was dead serious. I think, even the drug dealers, they want out of this too. They know they're caught in this and they're addicted. And he looked at me dead serious and said that. Now, he didn't come see me, but he at least, acknowledged, and then I'm sorry, the third part.
So we had vets, marijuana, and how does poverty exacerbate, certain breakdowns and stuff, and what role does poverty play in mental episodes and breakdowns?
So the basic theories are, and this isn't complicated stuff, I think this will make sense to people. They're, people who are poor or who end up being poor end up using drugs, alcohol, and having, they become traumatized just by going through the process of becoming homeless. And then there are people who are traumatized when they were younger. So there's studies done for people who want to look them up and read about them. The ACE studies, adverse childhood event studies, show for every risk factor you have, you're like so much more likely to become to become homeless, to become promiscuous, to become overweight, to have serious medical issues. So it's so important what happens to our little ones, that the poverty rates in our country are absolutely unacceptable. We can build F-14 B-1 bombers, but we can't take care of our children like they can in, say, Norway. It just doesn't make sense. And we end up paying the cost in far greater terms when they get older, because then that's when, people have all these medical, psychiatric, and addiction problems, and they're just in and out of hospitals, psychiatric, medical, They have high blood pressure. They have strokes. They use tobacco, which kills more than all other addictions combined every year. So, I mean, I could go on and on about this, but poverty is horrible. I mean, we all agree that. But what we do about it here is so different than in many other developed countries in the world. We give people health insurance in other developed countries, and we have a safety net that's very different than what we have here.
Yeah. So, yeah, my last question would be, I know that, I think you and I first met on Senator Sanders' campaign, and the big thing that motivated me, I mean, there's a lot of things about Bernie, particularly his environmental stance, but also having lived in England, Medicare for all. So maybe you could talk about, to close the show, on how many of these problems and obstacles, maybe you just list a few of the obstacles that would not be here. When we talk about some other countries that have different models in the developed world, most of them have some form of single payer healthcare. And maybe we could talk about some of the obstacles that you see in treating people that would not be there if we had a single payer system.
Sure. So there really are, in the simplest way of looking at it, there are problems for the providers, the physicians, nurse practitioners, physician assistants, et cetera. And then there are problems for the patients or for people. And of course, the ones for the patients seem insurmountable at times. They've lost their insurance. They forgot to recertify. They make enough money now that they don't qualify for Medicaid, so they have to go to the marketplace, which for some people is prohibitively expensive. There's co-pays, premiums, co-insurance. I mean, it's impossible to even understand your program. And then to understand, for your health insurance, it's a carve out, so it's a totally different plan. And then for your drugs, you have a prescription drug program. Maybe you have Medicare and it pays only for 80%, but you might have Medicaid as well. I mean, I'm just starting to talk and I start to get anxious because there's no way to figure this stuff out. And you almost feel like that's the way it's set up, to discourage people from even using this. And then the health insurance companies make money. The executives get millions and billions of dollars for denying care. It just doesn't make any sense. Other countries have figured this out. Every other developed country has some form of national insurance, national health insurance. And they use different models. There's no one single model that seems to be perfect. Many of us believe the single payer model, where you still have, it's just publicly financed. That's the public part. It's publicly financed using the most efficient model we know of, the Medicare model. But you still have physicians practicing privately. So, people don't feel like they're a government employee. Some people believe that's a bad thing. They don't want to be a government employee. I was for years and I loved it. It has its benefits for sure, and it's not perfect. But what we see is, particularly from my side of the street, is the patients who, I'm a very conservative prescriber. I use old generic medications. Why are insurance companies making me fill out paperwork to give money, to give medications that cost pennies on the dollar compared to some of these other meds? It doesn't make sense. It's because that's their reflex, is deny everything, and then you keep costs down because they're there to make profits. They are legally required to make profits. That's what corporations legally have to do. If they don't, the CEO will just be fired and someone else will be moved in their place. And so it feels impossible. And then the patients get so frustrated and they get angry at us at times, which, fair enough, I can take it. But it's not fun when the patients think we're screwing them around when we're actually trying to provide treatment. But if you don't come to treatment, you lose your insurance, you don't come to treatment. In addiction, people die. They just go back to heroin. They overdose. They go back to drinking. They're back out on the street. They get shot or stabbed, and so the stories, unfortunately, can have really sad endings. I remember, I'll just finish with this brief story. So I worked with a guy for years. I mean, just the classic Syracuse guy. He'd had a really rough life when he was little. But he came back from his addiction and he started working, and his employer wouldn't let him work over a certain number of hours per week because then they'd have to pay for his health insurance. And it was just so upsetting, and he relapsed, you know, and he came back and he got back into treatment, but you just feel like why does this stuff have to happen? Like he lost his Medicaid, he had to buy private insurance, and it just, you know, people end up spending so much time on trying to understand health insurance rather than just getting treatment. You know, when you have a deadly disease like addiction, it doesn't seem fair to like the working class folks who are just out there trying to do the right thing and work. And you know, he was a security guard. He was providing security for other people, and he'd overcome his addiction. And I don't know, it just is so frustrating and demoralizing as a physician to see that. I live a life of privilege, and I see working people suffer, and it really sucks. I hate it.
Yeah. Well, I appreciate you, Sunny. As you said, this can be a heavy load to bear for people in your profession. I can only imagine, to be honest, you know, in my brief touches with mental health, in people around me and my own struggles with stuff, I can only imagine swimming in this stuff and deciding to call it your career. But I know it must be rewarding, but it also must be truly exhausting at times. So I appreciate you, you know, for all your work and for coming on and talking to us openly for this hour. And maybe when we find out about your grant, you can come back on and talk to us some more and tell us what's going on, and we can dive into some more of these questions, because the online questions were great as well.
No, I loved it. Thanks for having me. It was an honor to be here. I appreciate all your work too, Joe.
Yeah. Well, I will catch you again soon, my brother. Peace and love. Thanks for coming on, Sunny.
All right. Take care.
Take care, brother.
All right. Bye.